Hello, hello. Good morning, good afternoon, good evening, wherever you are. Welcome to another Intensive Care Hotline and Intensive Care at Home live stream. My name is Patrick Hutzel. I'm your host for today's show. We will answer all questions intensive care and intensive care at home related. And today's title is The ICU team is guilt tripping me to stop treatment for my 82-year-old dad in ICU. Help. Now, before we go into today's situation, into today's case study, I will, I'll also answer all of your other questions. You can type them into the chat pad, or you can call live onto the show on one of the numbers that I put into the chat pad. Before we dive into today's topic, quickly about me. Again, my name is Patrick Hutzel, founder of IntensiveCareHotline.com, where we consult and advocate for families all over the world. And we have been doing so for 10 years now. And we predominantly help families that have a loved one in intensive care, help them get peace of mind, control, power, and influence, and help them to make informed decisions, because it's very difficult to make informed decisions when you have a loved one in intensive care and you only hear a one-sided story from intensive care teams. It's always good to have a balance of views, because it's not a one-size-fits-all when someone is in intensive care. There are many different approaches that might be working for different families. So I'm a critical care nurse by background, and I have worked in intensive care / critical care for over 20 years in 3 different countries. I have worked as a nurse unit manager for over 5 years in intensive care, and I have also been the founder of Intensive Care at Home. I am the founder of Intensive Care at Home, where we send intensive care nurses into the home for predominantly long-term intensive care patients and long-term ventilated intensive care patients, adults and children for that matter, with tracheostomies, but also for non-invasively ventilated patients with BiPAP, CPAP, and also for patients on home TPN. There's also seizure management we're providing at home for some of our clients. So that's a little bit about me. As I said, please type your questions into the chat pad, and I will answer them as we go along. But let's get to today's topic. And I just need to quickly grab my notes. And let's get started today. So again, today's topic is the ICU team is guilt tripping me to stop treatment for my 82-year-old dad. Please help. So this is a real case study today where I want to focus on. So we are currently working with a client who has their 82-year-old dad in ICU, and initially he went into ICU with COVID pneumonia, and initially the ICU team put him on BiPAP, was alternating between BiPAP, not intubated, so BiPAP is just a mask, face mask that provides mechanical ventilation. It was on BiPAP initially, and he was alternating between BiPAP and high-flow nasal prongs, and the goal right from the start was to keep him off intubation, because the intensive care team thought he wouldn't come off intubation, and initially we agreed that the goal would be to keep him off mechanical ventilation and intubation at all costs. His arterial blood gases were pretty poor as part of the COVID pneumonia, and the ICU team seemed to succeed with their strategies of alternating between BiPAP and high-flow nasal prongs or high-flow nasal cannula. Then what happened next was, the ICU team was still was very negative and saying, look, we don't think it's a good idea to treat your dad in the first place. We think, you might be thinking about even stopping BiPAP and stopping high flow nasal cannula and let your dad go peacefully. But our client was very adamant, and the client is the daughter, to continue treating her dad because that's what he would want. And he would not want to leave without a fight. So that was her stand, and we made sure that she knew all the right questions to ask and how to advocate. Then the next thing that happened was that the situation really threw a spanner in the works. And what happened next was the client came to us and saying, look, my dad hasn't opened his bowels for a number of days. He's got a very firm tummy, and his infection markers are going up, and they're now doing a CT of his abdomen. And when the CT results came back, it was actually found that he's got a bowel perforation, a bowel leak. And that the ICU team said, we feel like he's not even getting through the night because he'll end up with abdominal sepsis. And if we're not operating on him right away, then he'll pass away. And they were still sort of honing in on that. They thought it was, quote unquote, in the best interest for this particular man to just pass away without any surgery. And again, our client was vehemently opposed to that and said, no, I want surgery for my dad. And at this stage, the gentleman was still awake, and he could express his own wishes. And he said, look, I do not want to die, and I want to have surgery no matter the outcome. Even if I die on the table, then I still know I've had the best chance to live. Then a general surgeon had a look at the case and was happy to take the gentleman for surgery. Now, at this stage, we felt like there were two options, really. One was he would end up with an abdominal sepsis. He would need to be intubated anyway, and he would end up on multiple inotropes, vasopressors, because part of septic shock is to drop blood pressure, to drop heart rate. White cell count goes up, the temperature is spiked, the typical signs of a septic shock. Or the other option would be he goes for surgery, he has a chance of recovery, and he'll end up intubated and on inotropes anyway. So in both situations, he would have ended up intubated and in a coma and probably on inotropes and vasopressors. In one scenario where without surgery he would have died, most likely, and in the other scenario, going for surgery, at least he has a chance of getting the bowel leak fixed and getting the abdominal sepsis cleared, and then try and get him extubated. So obviously the second path was chosen, and he had surgery. Just as we predicted, he came back intubated, came back on multiple inotropes and vasopressors, was started on antibiotics and had the bowel leak fixed. And then what happened next is quite interesting. The ICU team sort of still trying to guilt trip our client and saying, well, now he's on a ventilator and he's not having any quality of life, and you should either do a tracheostomy or you should let him die. And again, given what the client's father said before surgery, he said, well, I don't want to die. I want to have every opportunity to get out of this alive. And now the daughter is trying to advocate to have her dad extubated rather than having a tracheostomy. And we think that's the right thing to do, get him off the ventilator and avoid the tracheostomy. It's now been about a week where he's been intubated. It's been a week since surgery, and signs are there that he might be able to get extubated, and that he can avoid the tracheostomy. So overall, it's been a good success in spite of the ICU team trying to guilt trip this man's daughter and saying, well, you're cruel if you keep providing all this treatment for him. We don't think it's in his best interest. Well, he certainly thought it was in his best interest to live, and he thought it was in his best interest to have the surgery and have a go at it. So that was the situation there. So we see this all the time where families are being guilt tripped, for lack of a better term, and things are being thrown at them where, ICU teams say to them, well, if you continue treatment for your mum, for your dad, for your spouse, whoever it is, it's not in their quote unquote best interest. It's just suffering. And let me ask you this, if you are in intensive care, yes, there is suffering coming with intensive care treatment, but also people want to hang on to life at all cost. And that's human nature. That's normal human behavior. And nobody should be playing God to say when someone's time is up, right? I'm a big believer that all resources need to be used to keep people alive if that's what they want. If they don't want to, that's a completely different story. But in this situation, like in most situations that we're dealing with, patients and families want to hang on to dear life at all cost. And there's nothing wrong with that. And they are prepared to quote unquote suffer, whatever that may look like, So in this situation, again, the man has come out of surgery reasonably well, and he's slowly waking up, and he can start communicating, and they want to try and avoid the tracheostomy. But now again, the intensive care team is saying, well, it's all suffering for him, and if he has a tracheostomy, he will never come off the ventilator, and he will just, on an ongoing suffering. But all these options have been presented to the man even before surgery, and nevertheless, he wanted to go ahead anyway. Now, the other thing that's happened just from a clinical perspective here as well, because his bowels need to rest at the moment after surgery, he's now also on TPN, which is intravenous nutrition. It's just for anyone that's watching this video or reading the blog, that often when patients in intensive care can't get nutrition through a nasogastric tube, through a PEG tube, or even orally, and let's assume they're not ventilated, then TPN is an option. TPN is also known for intravenous nutrition. So there's a number of options how nutrition can be given in intensive care. So that's just, again, for general education purposes for families in intensive care. Now, next, let's just say this man can't be weaned off the ventilator, God forbid, and he needs a tracheostomy. Maybe it'll take a while to get him off the ventilator, but still, the man will be having more time to get off the ventilator, right? Often it's a numbers game. It's a timing issue, and even, let's just say, God forbid, if he can't come off the ventilator, there's options like intensive care at home. He could go home with a ventilator and a tracheostomy. And for example, with intensive care at home in particular, we are operating currently in all capital cities in Australia, but also in all regional areas in Australia. So if you are watching this and you are in Australia, you should contact us if you are in a similar situation with a loved one in intensive care, who's there long term, especially if it's a slow respiratory wean, slow wean off the ventilator, or even if your loved one is sitting on a ward, on a hospital ward, hospital floor with a tracheostomy and can't go anywhere in the community, we can help with all of that. Ventilation, tracheostomy care in the community, but also BiPAP or CPAP. And you shouldn't be too worried about funding. You should talk to us about funding. We can help you with all of that. None of our clients really are out of pocket. It's coming through the NDIS or other funding avenues. You should contact us. Anyway, coming back to the quote unquote guilt tripping that ICUs often put in front of families, where they say, well, if your loved one is suffering, it's your fault, and also implying that intensive care teams are the only ones that know best. Well, I'm a big believer that the only ones who know best is either the patient themselves, or if the patients can't be speaking for themselves or they can't make decisions for themselves, then families know best what their loved one wants. They know their patients, they know their family members, they know how they would react in certain situations. And again, it's not a one size fits all. If a family thinks in intensive care, hey, my loved one wouldn't want to live like that, my loved one wouldn't want to be dependent on a tracheostomy, wouldn't want to be dependent on a ventilator and so forth, and you think that they would rather pass away, then that may be the right decision as well. Again, there's no right or wrong answer. It's only right or wrong answers for you as a family. Keep that in mind at all times. Don't let anybody else tell you otherwise. Next, here is another thing. to keep in mind in those situations. So like we found with our client here, our case study today, the intensive care team only tells families half of the story. So when we work with clients one-on-one, we often find out that, when we get a summary of the things that happened to when we start working with them, intensive care teams only tell families half of the story. Case in point. So in this situation, the gentleman, before he had surgery and he got intubated, he had no nutrition for a number of days because he was on BiPAP. And when someone is on BiPAP, especially with pneumonia, there's a risk for aspiration. If you feed patients, there's a lot of pressure going into the stomach. And with that pressure in the stomach, there's a real risk for vomiting, and that could lead to aspiration. The last thing that you need or want is someone with a pneumonia aspirating into their lungs, because then they'll most likely end up being intubated. So, but what we found is when we went back to the family and said, well, yes, he might not need or might not be able to have nasogastric tube feeds or oral feeds because of the aspiration risk, but what about TPN? So TPN, as I mentioned a minute ago, stands for total parenteral nutrition. It's also known as intravenous nutrition. And then the family was told, oh, we don't do that here. And, that's a whole lot of garbage, excuse my French. But, TPN is being used in ICU all around the world every day for patients that can't take things orally, can't take nutrition orally or through a nasogastric or through a PEG tube. So then once we educated the family about TPN, then the ICU team was backpedaling and starting TPN. Again, it all comes back to that families in intensive care don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. That's exactly what this situation is once again. So, we see over and over again that when we work with families, ICU teams only tell families 50% of what's really happening, if that, right? Once we start breaking things down, once we look at medical records or talk to doctors and nurses directly, then we go back to families and say, well, what about this? What about that? Right? And the TPN is a prime example for that. Also, another issue in a situation like that is clearly that, families should take their religious, cultural, spiritual goals in mind for their loved one. If someone is religious and believes in God or in any other faith, and they, as part of their faith, stopping treatment is not part of that, then you need to communicate that to the intensive care team, and they need to respect that. We're living in very diverse societies nowadays, and the individual's wishes need to be taken into consideration depending on, again, their spiritual, religious, cultural, and individual beliefs. We're not here to judge that. We're here to facilitate whatever it is that is needed. And that is also known as holistic healthcare. And holistic healthcare means we're looking at it from all angles, right? Which includes the individual and the family. Next, one way out of this dilemma is clearly an advanced care directive. So why is this important? So very few people in intensive care or very few people in healthcare have an advanced care directive. So what does that mean? So an advanced care directive is a legal document where it's documented, where your wishes are documented, that if, God forbid, you end up in intensive care or you end up in a nursing home, whatever, what are your wishes? What do you want? Do you want to have treatment for everything that's happening? Do you only want to have treatment for certain things? Do you want to be resuscitated? Do you not want to be resuscitated? So the clearer you can be upfront and having it documented and signed, the better it is, because then there's no ambiguity. A lot of the issues in situations like that coming from ambiguity, where families don't know what to do, because there is no documentation. They have never discussed it with their loved ones. And that's a big issue because, it's very confrontational, talking amongst families even about what would happen, in situations like that. What do you want? What do you not want? And there very difficult conversations to have. They're very difficult decisions to make, because even though you might say, oh, I don't want to live on a ventilator, you might wake up and you might have second thoughts, and you might be on a ventilator. You might have second thoughts. Just don't know. So I hope that illustrates the situation. Hi, Modema. Sorry, I didn't check my comments. Hi, Modema. Nice to meet you. Nice to see you again. So, do not let anyone guilt trip you. A lot of the guilt tripping in ICU is simply coming from a place of, well, we need ICU beds, but they're not telling you that. ICU beds are in short supply. And because ICU beds are in short supply, one way to empty ICU beds is to stop treatment for people. Right? For our friends in the US, one way to empty an ICU bed is to do a tracheostomy and send patients out to LTAC. Rather than doing an early tracheostomy, maybe the questions need to be asked, how can we avoid a tracheostomy? How can we make sure that we get a patient off the ventilator beyond the shadow of a doubt? How can we facilitate that? So, there's many considerations in situations like that. Okay, so I hope that clarifies. Let's move along and let's look at some other emails that came in this week, and let's answer some other questions. If there are questions around the case that I just presented about the quote-unquote guilt tripping of families in intensive care, let me know. Type them into the chat pad or dial in live on the show. Now, the last thing that I will say about guilt tripping, you can't control the intensive care team. Whatever they say to you, they say to you. Don't worry about it. Don't control it. But what you are 100% in control of is how you react. You don't need to buy into the guilt tripping. You are a human being that can think for themselves, and you can make up your own mind. You don't need anybody how to tell you how to deal with treatment for your loved one. Right? If you want everything done, you want everything done. You don't need to explain. You don't need to explain. It's your choice. Okay. And also, with one more thing about the guilt tripping. Here is another strategy that intensive care teams often use, and I see it over and over again. I've seen it, when I was still working in ICU. There's so many families that come to us and say, oh, the intensive care team told us we need to go to a family meeting tomorrow at 3 o'clock to discuss the case, to make a decision. Well, maybe not. Who says you need to go to a family meeting, especially if you are unprepared? Because most family meetings are about guilt tripping. If the intensive care team asks you for a family meeting, especially at short notice, don't drop everything. Ask them for a written meeting agenda. Those family meetings are potentially about life or death. You do not want to go there without a written meeting agenda, and you don't want to go there without being represented. We can do the representation for you. We can ask the questions on your behalf. I argue we ask questions that you haven't even considered asking, because remember, the biggest challenge for families in intensive care is that they don't know what they don't know. Okay, let's look at some questions from this week. The first question is, hang on, that question, sorry, that's an old question. I do apologize. Let me just scroll through my emails there. Just bear with me. Yes, here's a good case from actually a reader that wrote in this week. Sorry, it's a bit small there. that writes in, I got diagnosed with serotonin syndrome. I had a big seizure at home. When I stopped having the seizure, I had psychosis, couldn't remember who I was or my family was. When the paramedics turned up, I ran away thinking they were going to kill me. My brother-in-law found me wandering the streets with no shoes on and at 12 o'clock at night. He took me to a hospital after managing to talk to me into getting into his van. By the time I made it to hospital, I was starting to come round, but still didn't really know what had happened. I fell asleep in hospital for 4 hours, then woke up. That's when I had another big seizure and was rushed into resuscitation when they put me into a coma and on a ventilator. I had some crazy hallucinations and dreams. Whilst in a coma, both my kidneys failed. My right lung collapsed and I had pneumonia. I spent 4 weeks in a coma. They tried to wake me up every day, but I would get agitated and try to rip my tracheostomy out. Eventually, they woke me up on the 4th week and I wasn't so agitated. I was so confused when I woke up. I thought the dreams and hallucinations had really happened. It took me around 2 to 3 days to start to remember who I was and who my family was. I couldn't walk and could just about lift my arms. My kidney made a full recovery thanks to dialysis. The pneumonia cleared up and my lungs repaired. I eventually left hospital in a wheelchair. 2 months later, I returned to work as a roofer. Then my job and driver's license, I started to return to work as a roofer. Then the first COVID lockdown hit. 2 weeks into lockdown, I had another grand mal seizure and ended up in hospital. That's when I was diagnosed with epilepsy. I lost my job and driver's license and started having around 2 grand mal seizures a month, ending up in hospitals. I tried 3 different medications that didn't work until eventually my neurologist put me on Keppra and Bimpap. I'm now 17 months grand mal free. Unfortunately, I've started having focal aware seizures, but I can handle them. I'm now back at work. I still don't drive, but that's my choice to never get behind the wheels again. I'm on the up now after 3 years of fighting. My life has completely changed. I'll never be the same person again I was before, but it's possible to live a decent life, never give up. So this is an email we had from a reader this week. Isn't that amazing? Isn't that amazing? Now, this comes from a reader. It doesn't come from a family, but I'm pretty sure that whoever, this family is looking after their son while they were in ICU, I'm pretty sure they would have had all the talks that we just mentioning before, the guilt tripping, that he will never wake up, he will never get out of here, he shouldn't have a tracheostomy. And here we go, here's this man telling his story saying, do never give up. Now, he doesn't share his age, but given that he's working, he must be working age. Well, that could be anywhere, really. Anyone, even some 80-year-olds can work, but that's an amazing story. And it's another sign that you should never give up. We're getting emails like that every day, So that's really an amazing story that I wanted to share. And I think it is important for families to understand what is on the other end. And clearly here, what is on the other end is a recovery and someone saying, do not give up. So then let's go to the next email. So the next video is from Dorothy. She says, thank you for all your videos and case studies. My father is 85 years of age and is in ICU, and doctors are insisting on a tracheostomy as he has a chest infection. A few days back, he had undergone head surgery, but he gained consciousness the very next day. The doctors took out the ventilator, and after that, his CO2, also known as carbon dioxide, accumulated in the lungs. So they again put my father back on the ventilator. But now the doctors are insisting for a tracheostomy tomorrow. Could you please guide for any alternative methods so as to avoid a tracheostomy? Okay, so the question here is, why are they insisting on a tracheostomy? Is it because he has a chest infection, or is it because he had undergone head surgery and he's not waking up? Is it potentially a combination of the two? If the chest infection is not clearing up for whatever reason, are they giving the right antibiotics? Are they using the right ventilation strategies? Are they trying to wake him up? Right? So, and then if his CO2 accumulates when they're taking out the ventilator, why has it accumulated? Did they not put him on BiPAP? Right? So if they took out the breathing tube, they should have tried BiPAP. Why did it fail potentially? Did they use BiPAP in the first place? So, there's a number of reasons. For example, did they even sedate him when he was on BiPAP? Right? So there are a number of questions here, Dorothy, that need to be answered before I can answer your question. Jolene, I'm seeing your question here. I'll just finish off the email here from Dorothy, and then I'll come to your question, Jolene. So Dorothy, there are a number of questions that need to be answered. So first thing, why did he have surgery on his head? Does he have a brain tumor? Did he have a stroke? Why did he have surgery on his head? And is there some ongoing brain damage? If there's some ongoing brain damage, is your dad potentially not being able to swallow? Right, if he's not able to swallow, then he will need a tracheostomy in the long run until he can swallow again. Right? So then, is he still foggy from the brain injury? Can he not protect his airway because of the brain injury potentially? You're not talking about a brain injury, but you are talking about head surgery. Again, why did he have head surgery? Right? Is potentially his respiratory drive suppressed because there's something wrong with the brain? If the alternative to a tracheostomy is this: wake up, right? Try and wake up your dad, start physical therapy, wean him off the ventilator, step by step. There's a video and a blog post that I made about how to wean a critically ill patient off the breathing tube and the ventilator, right? You should check that out. You should type this into Google. Type into Google, or on our website, there's a search box, how to wean a critically ill patient off the ventilator and the breathing tube intensive care hotline. So have a look there. If the tracheostomy can't be avoided, Dorothy, then you need to look at what are the next steps. Can he be weaned off the ventilator? If he can't be weaned off the ventilator with a trach, right, look at intensive care at home options, right? Contact us at intensivecareathome.com. Go and check that out, intensivecareathome.com. Okay, I hope that helps, Dorothy. So now Jolene's got some questions. Jolene, you're saying, my boyfriend was taken off life support Friday after 10 days in an anoxic coma. They shut me out of all decisions, even though we had been living together for 15 years. He passed away Friday at 5:56. I'm very sorry, Jolene, to hear that. And my condolences to you and your family that your boyfriend has passed away. That's incredibly sad. You are furthermore saying the family didn't allow me to be there and didn't tell me until 4 hours later. Oh my God, the ICU team didn't try anything with him. His family refused the doctors I had set up for second and third opinions, which his insurance would have covered. That's a very difficult position to be in, Jolene, and unfortunately, we have many people in your situation coming to us where they say, hey, I'm the partner, I'm the boyfriend, I'm the girlfriend, whatever. And as long as you are legally not the power of attorney, there's not much you can do. You might have lived together for 15 years. If you are not the power of attorney, you have no rights here whatsoever. Please bear in mind, I am not a lawyer. I'm a clinician. I am not a lawyer, but I can tell you from experience that in those situations, you have no rights whatsoever. I'm sorry to break the news, but whoever was your boyfriend's power of attorney, mother, brother, sister, father, who knows, would have had all the decision-making authority here. And the reality is that people who watch my videos and people who participate on these shows, they're in the minority. 99% of families in intensive care don't question. It's just a reality. So I assume, Jolene, that your boyfriend's family didn't question either. And unfortunately, these are often the outcomes. It's very sad. It's very sad what's happened here. What you might be able to do, but even that will be difficult, if you were the power of attorney, and you would have access to the medical records, we could look at them and we could tell you whether, we could give you that second opinion. That'll be very difficult to ascertain for you, I believe, because you're not the power of attorney. And you're sharing here after 10 days in an anoxic coma. 10 days in ICU is not a long time. I've made countless of videos over the years where I talk about the difference between a real and a perceived end-of-life situation. Now, I don't know enough about your boyfriend's case. Maybe the only option for him was end-of-life. I don't know. Don't know the ins and outs. But there's a big difference in intensive care between a real and a perceived end-of-life situation. And I argue most situations in ICU are perceived end-of-life situations. So what I mean by that is a real end-of-life situation is whatever you do, whatever treatment, whatever resources you throw at a critically ill patient, they're not going to survive. Right? That's a real end-of-life situation. Perceived end-of-life situation is, well, you haven't thrown all resources at it and you're not prepared to try. Right? So therefore, this patient is most likely going to die. That is a perceived end-of-life situation, because if you are trying, then maybe you can save someone's life. All right? I don't know whether your boyfriend was in a real or in a perceived end-of-life situation. I hope that helps to clarify. And again, I'm very sorry. My sincere condolences to you and your boyfriend's family as well. This is very sad, and unfortunately it happens all the time in ICU. Okay, let's move on to the next question. And that is from Bree. Bree says, my mom is 61. She had a heart attack and cardiac arrest for 30 minutes. It has been 5 days. She's awake. She's breathing on her own. She reacts to stimulus and she will use her eyes and head to follow me. We are not sure to the extent of her brain injury, but all these signs give us hope. She still has the ventilator in because she isn't following commands yet, and the doctors are afraid she won't be able to clear her pathway. We need to make a decision on putting on a trach or letting nature run its course. Okay, so the first question is that your mom had a heart attack and cardiac arrest for 30 minutes. So first question is, how long was the quote-unquote downtime? Did her brain not have any oxygen for more than 3 minutes, and is there potentially irreversible brain damage? That's the first thing that needs to be established. Now you haven't mentioned anything that your mom had a CT scan of the brain, an MRI scan of the brain, an EEG, neurologist input. You are not talking about that. That would be my first question, right? The next question is if she uses her eyes and her head to follow with, that's a good sign. The next question is, was she in cooling therapy? Many patients in ICU that have a cardiac arrest go into cooling therapy to preserve all organs. Has that happened? And that includes the brain, to preserve the brain function as well. She still has the ventilator in because she isn't following commands yet, and the doctors are afraid she won't be able to clear her airway. So what that possibly means is if she's still sedated, she probably won't be able to clear her airway. She won't be able to cough. Chances are she needs to be woken up. She needs to be off sedation completely to see what she can do. Can she cough? Can she wake up? You haven't mentioned whether her sedation is off completely. Next question is, does she have seizures? Many patients with brain injury after cardiac arrest, after an anoxic or hypoxic brain injury, have seizures. You haven't mentioned anything there. So chances are that if she is having seizures, that there's also some brain damage. Please bear in mind, I'm not a neurologist, but I am talking from my extensive experience as a critical care nurse here. So you need to establish if she's off sedation, off all pain medications, because that puts her in a position to wake up, presumably, assuming there's no brain damage. But all these things need to happen simultaneously for her to wake up, and that can take time. Now, it's only been 5 days. 5 days is not a long time. Not a long time at all. Your mum might need 2 weeks, 2 months to wake up. We don't know. The next question is, what ventilator settings is she breathing on? Right? Is she breathing spontaneously already? Or is she, is she breathing spontaneously already, or is she still fully ventilator dependent? If she has brain damage, does she have a gag reflex and a cough reflex? Because the intensive care team is referring to, she won't be able to clear her airway, right? And that might well be the case. We need to make a decision putting in a tracheostomy or letting nature run its course. Again, is she breathing spontaneously? What's her Glasgow Coma Scale? Check out Glasgow Coma Scale. Go to our website and type into the chat pad, into the search box, Glasgow Coma Scale, right? Chances are your mum might need a long time to wake up if she does have brain injury. Talk to a neurologist. If she does have a brain injury and she can't be weaned off the ventilator, or she can be weaned off the ventilator, but needs a tracheostomy, then look at home care as well. Now, let's just quickly go back to Jolene, because Jolene has a number of more comments there, and then I'll come back to Bree. So, Jolene, you're saying you're thinking about doing that. I assume getting access to medical records. They made it all about how his son would feel during his recovery and not about him. That's right. I don't know how old your boyfriend's son is. Children are very good at adapting. I don't know whether your boyfriend's son is a child or an adult. I wouldn't know. But at the end of the day, children are very adaptive. Okay. Then you are saying the anoxic brain injury was caused by an ICU doctor who was a medical student who moved in while he was not stable and didn't look at his previous medical records because they weren't in his chart. Then Modema, you said, surely as a de facto you should have had rights as a spouse. Then Jolene says, the thing is, we had talked about this together and he has told me he feared being shut off. Then Modema says, that's awful. Was it ARDS pneumonia related? Then Jolena says, this is also terrifying, and it's a travesty that most have no idea about the disposable attitude they have towards life. Yes, absolutely. That's why we're doing these shows here, to get perspective and counteract the mentality that a life can just be disposed, because it can't. The problem in intensive care is that, intensive care professionals are often desensitized because patients are just numbers, just another number in a bed. And from experience, I can tell you, if you have someone in an ICU bed on a ventilator, patients, for lack of a better term, they all look the same because they're all in a coma, they're all on a ventilator, right? Whereas for you, this is your boyfriend, this is your mum, this is your dad. For you, it's not a number, right? So this is very, very important to make that distinction, that intensive care health professions are desensitized towards that. It's that disposable attitude. And Modema, I know you experienced the same with the loss of your husband, I know. So Jolene, you're saying, I really want to participate in activism to raise awareness about treatment of brain injury patients. Yeah, it's very unreal. It's very unreal. You think that intensive care units will move heaven and earth to save lives. Problem is, they need to save many lives. You know, the demand on intensive care beds is very high. That's number one. Number two, there are real staff shortages because it takes years to train in intensive care. Right? It takes years. You know, so those are all real time challenges that people are facing. So I just had a missed call because while I was talking, I'm just wondering whether this is someone that wants to dial in live on the show. I'm just calling this person back. I'll just put myself on mute quickly because I don't want to. Just give me 1 second. I'll just go on mute for a second and see whether someone wants to dial in live on the show. Just give me a second, please. Apologies for that. So yes, and Modema, you're saying Patrick is the only one that's available for information and advocacy. I wish I found him when my husband was ill. Look, I'm not sure that there's anybody else available. Surely other people would have identified the need for it, but maybe they don't want to speak up. I don't know. I really don't know. Okay, so quickly coming back to my earlier question where Bree asked, I'll read out the question again. My mom is 61. She had a heart attack and cardiac arrest for 30 minutes. It has been 5 days. She's awake. She's breathing on her own. She reacts to stimulus and she will use her eyes and head to follow you. We are not sure to the extent of a brain injury, and all these signs give us hope, but still has the ventilator in because she isn't following commands and the doctors are afraid she won't be able to clear her airway. We need to make a decision on putting a trach or letting nature run its course. Now, Bree, it's only day 5 for your mom. You know, if she's already waking up, you might want to give it a little bit more time. A tracheostomy only needs to be done between day 10 to 14. So, you know, you might give her more time to wake up. Make sure she's off sedation. Make sure she has no seizures. If she can't be off sedation because she's fighting the ventilator or she's having seizures, chances are she might have brain injury. But your next step is to talk to a neurologist. That is your next step. Okay, and keep watching out. Keep looking for the signs of her coughing, of her having a gag reflex. She needs all of that to have the trach removed. We also need to make a distinction here that some patients can live without a ventilator, but not without a trach. Some patients can't live without a ventilator and without a trach, right? And then there's others, they can live without a trach, but they need BiPAP or CPAP ventilation. So it's it's a tricky one, but it's way too early to call the shots here, Bree. Way too early. Day 5. It's not 5 weeks. It's only day 5. Very early days. So give this time and watch for signs of your mom waking up. Okay, Jolene, you were saying, I really applaud you for your unyielding efforts in helping to bring light to this horrible situation. Thank you. Oh yeah, it's a pleasure. I enjoy what I'm doing. So thank you for your kind words. Okay, let's move on to the next question. We have time for one more question. Okay, so here's an email from Siabu that came in this week, and she says, "Hi Patrick, my father had a car accident, and after the impact he had brain surgery. The right side of the bone was broken and a small part was touching his brain. Blood also flowed out. Now, after the operation, he has been in an induced coma for 5 days. What can be done? Okay, thank you, Sirbu, for your question. Again, similar to the previous question, 5 days in ICU is not a long time. Not even 5 weeks in ICU is a long time. Now, the question here is this, Sirbu: did the bone that they operated on, did it touch the brain, and was there some brain damage from that? Okay, that's the first question. If there's no brain damage, then maybe he has some other injuries. If he has been in a car accident, maybe he's got other fractures, I don't know, that keeps him in the induced coma, right? You haven't mentioned any of that. Sometimes they might have repaired the bone on the brain, and they might have followed up with a CT brain scan or with an MRI brain scan, and the brain looks fine. There's no brain damage, but maybe he's got some rib fractures from the accident. Maybe he's got other fractures. Maybe he's in so much pain that they need to keep him ventilated for now and in the induced coma. Maybe he's waiting for other surgery. Maybe he's got a fractured hip, fractured femur, fractured shin bone, whatever, and he's waiting for surgery, and that's why they keep him in an induced coma. And once surgery is done, maybe that's when they can wake him up, right? So 5 days in ICU in an induced coma is not a long time. Obviously, you've got to ask the question, why is he in the induced coma? Maybe there's a valid reason for it. There probably is. You just got to find out what the reason for this is. Now, here's another tip. So let's just say he does have brain injury. Does he have an intracranial pressure monitor in? Right? Sometimes when patients end up in ICU with brain injuries, they might end up with an intracranial pressure monitor to measure the brain pressure. Right? If it's too high, it needs to be managed. If the pressure is too high, it can cause irreversible brain damage. Okay, maybe that is the reason why he's still in an induced coma. Maybe they need to get the pressures under control. Right? Maybe he's got an EVD, an extraventricular drain. Maybe, again, pressures are high, and maybe they need to drain brain fluids, right? Also known as CSF, cerebral spinal fluid. Okay, so again, the biggest challenge in intensive care for families is that they don't know what they don't know. And I'm glad you're reaching out there, Sirbu. Okay, so many unanswered questions here, but you can see, with having had an accident, are there any other injuries, that keep him ventilated for now? Okay. Modema, you're saying ICU is another world with another language. It's very easy to get bamboozled and take a step back. Yeah, absolutely. You got to look at it from the outside in. You can't look at it from the inside. You got to take a step back, do some research, and look at it, what's really happening. Jolene, I just had to share this video with his sister, as I have all of the other videos. I will never stop trying to educate them. Yeah, it's never too late, Jolene, because God forbid it might be someone else within your family tomorrow. It's never too late, Okay, look, I'm slowly going to wrap this up today. We're going nearly for an hour. Please keep typing your questions into the chat pad while I'm slowly wrapping this up today. Thanks for your questions and thanks for your support. And if you're watching this as a replay, I do these YouTube lives every week, usually on a Sunday morning, 10:30 a.m. Sydney, Melbourne time, which is 6:30 p.m. Eastern Standard Time in the US, and it's 3:30 p.m. Pacific time, and it's usually around 11:30 p.m. UK time. So I'll be back again next week around the same time, 10:30 a.m. Sydney, Melbourne time, on a Sunday, 6:30 p.m. Eastern Standard Time in the US, 3:30 p.m. on a Saturday, Pacific time. Now, if you have a loved one in intensive care and you have questions, go to intensivecarehotline.com and call us on one of the numbers on the top of our website, or simply send us an email to support@intensivecarehotline.com as well. And if you have a loved one in intensive care and you want your loved one at home, especially if they're long-term ventilated with a tracheostomy. And if you are in Australia, we operate with intensive care from all major capital cities in Australia, including rural and regional areas. You should contact us as well. If you are looking for intensive care at home in the US, we can help you in certain locations. Please contact us as well, the same in the UK. Now, we also have a membership for families in intensive care at intensivecaresupport.org. There you have access to me and my team 24 hours a day in the membership area and via email. And if you need a medical record review, you should contact us as well. We do review medical records in real time and also after intensive care, but it's so much better if we can review them in real time. With all those cases that we talked about today, you know, if we have access to medical records in real time, we can give you a second opinion very, very quickly. You don't want to come to us a year afterwards and say, hey, I need closure. I don't know what happened here. You know, we can do that, but it's often too late. You get it. It's much better if you get the reviews from us in real time. And in this day and age, ICU should just give you a link to a website with a username and a password, and you should have access to medical records in real time. And if you're struggling with that, let us know. We can help you. Okay. Now, thank you so much for watching. Subscribe to my YouTube channel for regular updates for families in intensive care and the YouTube lives. Click the notification bell, click the like button, and share the video with your friends and families. And comment below what you want to see next or what questions and insights you have. I can get your questions addressed on the next YouTube live or in a quick tip video. Jolene is saying it's very frustrating to know what other outcome may have been possible. I don't know how I am going to ever stop ruminating on the thought. May I ask how long ago this happened? Thank you so much. It really helped me so much. It's a pleasure. It's a great pleasure. Okay, I got to go now. Got to wrap this up. I don't know how the two of you can stay in contact, but I got to go now. And I want to thank you for your attendance and for your support. Thank you so much. Take care for now.